Welcome to the Australia-Indonesia Centre and our In Conversation webinar on public health policy responses to coronavirus, a discussion between Indonesia and Australia. I would like to start by paying our respects to the traditional owners of the land and acknowledging the Kulin nations on whose land the centre stands in Melbourne. I would also like to acknowledge the Yagara and Turrbal traditional peoples on whose lands our guest panellist in Brisbane, Professor Charles Gilkes, is talking to us from.
We're talking about the coronavirus again, and how can you not? It is such an incredible event globally. And of course, here at the Australia-Indonesia Centre, we're interested in what the two countries can learn from each other about it. Now, as you know, we've had a discussion about the economics, and there are more of those discussions to be had. Of course, the other important aspect is the impact on people's health and the way that government and policy officials are responding to this pandemic. So we're going to have a chat about that today. We're going to look at the different types of public health policy that are being applied, how they fit with the scientific evidence or the past evidence. What are scientists trying to tell the government about the best way to go forward? How do we manage the coronavirus in countries where there are disparities of wealth, where there is inequality, and where perhaps not all the measures enacted are going to work quite the same? Are the measures timely? Are they effective? We'll also be talking to an expert in viral transmission to get a bit of a better understanding of what might be going on. So much is not known about this COVID-19 virus. Could you please join me in welcoming our three guest speakers? We have Dr. Sudirman Nasir, who is a senior lecturer at Universitas Hasanuddin in Jakarta. We have Professor Charles Gilkes, who's the head of the School of Public Policy at the University of Queensland, an expert in infectious diseases. Thank you so much for your time today, Professor. And we have Dr. Yulia Sofia Tin, who's a lecturer in epidemiology from Universitas Padjadjaran. Thank you very much for your time today, Ibu, as well. So as you can see, three learned people to take us through, and we've already received a couple of questions, which is fantastic. We'll be asking for questions a bit later on as well. Now, before we go into the discussion, I wanted to set the scene a little bit because so much has been happening in the past week in Indonesia and Australia. In Indonesia, there was an initial move at the end of March where a state of emergency was declared and public places, many of them were shut down. It was advised that people work from home. We've seen then that the message has moved through from, say, a recommendation or a suggestion to enforcement through something known as the PSBB. Now, this means that officials can move stronger against gatherings of people. They can put in place measures just to stop workplaces from not allowing people to work from home. And these regulations are very similar to the ones we see in Australia, where they put restrictions on movement except those in essential sectors, such as the financial, fuel, food, medicine, and retail. Interestingly for Indonesia, they have banned the large-scale movement of people, the annual traditional going home to your village known as mudik. Now, this only happened in the past week, and there was a lot of conversation around that. This is where you see hundreds of millions of people moving around the country. So we'll discuss the impact of that government decisions. Religious leaders have also stepped in now too and given some guidance to people who were concerned about not being able to go to a mosque to pray, for instance. We'll cover those areas. And we'll talk to, we've got two doctors in our guest list, which is fantastic. We're going to talk to them about what's been happening in the scientific community around government policy and the sorts of concerns they've perhaps had in the past. We are, as I mentioned, also joined by Professor Charles Gilkes, who is an expert in infectious diseases and transmission. And he's going to give us some perspective on the measures that have been taken in Australia and how they apply to the science of these sorts of outbreaks. So without further ado, let's get going. And Dr. Sudi, if I could ask you first, given that there have been so many changes in the past week on government policy around how to protect the health of Indonesians, what changes have you seen in Indonesia since those announcements?
I think in the last few weeks, we start to see some improvement in government responses, as well as community participation for several preventative measures. Law enforcement in relation to large-scale restriction has increased and improved significantly in several cities, including in Makassar, the city where I live. And we also start to see improving coordination between different level of governments in Indonesia, particularly between the central government, provincial government, and district city governments in delivering social safety net programs for people who need some support in the current economic slowdown. So there are some improvement, even though huge challenges still remain in many parts of Indonesia, considering the complexity of the nation in terms of big number of populations, and also the archipelago, the thousands of islands, and also some other socioeconomic factors such as inequality, and also the large number of Indonesia's workforce working in the informal economy that hinder many of them to employ consistent preventative measures, including complying to government's instruction for working from home and other preventative measures.
What do you think prompted the government to make these stronger enforcement measures? Because earlier on, there was a very strong message from President Joko Widodo that he didn't want to do too much of a lockdown, and that he, it seemed, was concerned more about the economic impact than the impact of the potential spread of the virus.
Crucial, related to what you mentioned, the large scale of people movement during the holy month of Ramadan.
Dr. Yuli, if I could go to you, because you are amongst, well, in your community of doctors and scientists, this has been obviously a significant topic of discussion for you. How do you feel now about the changes that the government has made enforcing stricter measures on the movement of people and access to health facilities?
Beg your pardon?
Oh, sorry, Ibu, I'll ask that again.
I cannot hear you. Sorry.
That's all right. Can you hear me now?
Yes.
Ah, great. Thank you. Just wondering, you're in a community.
Can you?
We can hear you. Yes.
Can you repeat the question?
Absolutely. Yes. What are the concerns been?
Helen?
There have been many concerns in your community of scientists and health workers around the government policy. How do you feel at the moment about the direction the government's taking? Do you think they are listening more to the science now?
I believe so. At this time, they seems to hear us more. Everybody expect the containment, which was not approved at the beginning of the epidemic, but now it is now going on here in Indonesia. In some areas, we have large-scale social distancing. It is running now, but a lot of problems still happening. Actually, the government, the local government asked for more stringent measures. They asked for public transportation to stop, but it's still going on. Up until yesterday, I believe, the mudik has already banned, but no law enforcement. So it is difficult for the community to follow the rules. They want to go home. They don't have any job in the city, so it's quite difficult for us to follow the containment at the time.
Professor Gilks, in your experience, how important are these sorts of measures, and I guess how do you build community legitimacy around them?
So these measures are very important, and I think there's universal agreement and consensus across the scientific communities and in most countries across political leaders and religious leaders, indeed, that these measures are important. But they have to be based on community consent. And this is gained by clear communication by leaders around what is necessary and why it is necessary. And that has happened in Australia. I think there has been very clear leadership and communication of the need to enter some form of social isolation to prevent community transmission of SARS-CoV-2, the virus which causes COVID-19 disease. This is as well as the fact that Australia has very, very carefully enforced restrictions and closed the borders essentially to try and prevent people infected in countries where the virus is transmitting quite rapidly from bringing that virus into Australia. The other thing about community consent that's been extremely important is that people have seen on the international news and television scenes of terrible problems in Italy and then Spain and Europe, and more recently, particularly in New York State and New York City in the US. And I think people here have all said, what can we do to stop this happening? And they've understood, because the policies have been clearly described and justified by scientists and doctors and frontline workers, why this is necessary. And people have responded and said, yes, we need to do that. We need to do what we can to protect ourselves and our communities, and also to try and limit a surge of infection and disease which would threaten our hospital system, which is a problem for everybody, regardless of whether you're infected with the virus and have disease or not. Because while this epidemic is going on, other healthcare issues continue. And one of the really interesting things that's seen in some countries, in Europe in particular, is that people have actually, with normal problems like blood pressure or diabetes or cancer treatment, they've actually been, or going to their community doctors or hospitals for routine tests and screening, they've not been doing it. And it's because partly they're scared that hospitals are places where they might get infected, but also it's to say, we don't want to clog up the healthcare services unnecessarily with our trivial problems and they're not actually always trivial, and they do need to go to see health practitioners. Mm-hmm. So that is the sort of extent of community understanding and the need to protect the hospitals and healthcare workers, and to do something to make sure in Australia we didn't see and repeat those awful scenes in Italy and Spain and so on.
Mm. Dr. Yulia, if I can pick up on that point around community understanding, do you think that understanding amongst Indonesians has been growing, and that there is more concept of how difficult this is to manage and how serious the situation is?
Oh, sorry, Helen. It's a delay in the sound, but I'll try to catch your question about the awareness of the community. It's it is the characteristic of Indonesian people is very widely varied. Some of them are very ignorant.
Oh, we're having some internet trouble.
Understand what happened to condition today. So we can see that some people still go outside, still praying, but in other condition, a lot of people scared to even to go to the hospital for even if they are already sick. They also put some stigma to those who found positive for COVID. So it's very varied in Indonesia for the awareness of the or the understanding of the community about the COVID-19. So that makes it more difficult for us to put the right measure for the whole community.
And thank you, Ibu. You picked up on the question well, and appreciate that you're battling on. Everyone's accessing the internet at the moment, so it makes it tricky. But it's so important to have your understanding and insight. Someone who's on the ground, not necessarily in Jakarta, seeing what's happening outside the major cities. You also, you're a doctor, you have patients, you have friends in the hospital system. What is the situation like for them in the health system at the moment?
I believe at the moment the situation is better. More special hospital for COVID and more referral hospital. So for those who are already sick, moderately or severely, at the moment they still we can still take them to the hospital. Even sometimes it's difficult to find them. But in the community, we have suspect patients that needs to be tested for COVID, but the test is very difficult to access.
Well, let's get back to that. I do want to bring back Professor Charles at this point, just talking about the disparity of understanding and also the different demographics of the groups, the inequality that exists in countries. Professor, you've worked in Africa on HIV, for instance. This is a situation that you're quite aware of. What in your experience have you found are some of the challenges in a country, say Indonesia, which is diverse, which has a large population spread out across many different stratas?
So every different, thank you for that question, Helen. Yes, so every different community will have its leaders, and there will be political leaders, there'll be religious leaders, there will be leaders in different respects. And it's really important that they all say the same thing, even if they have slightly different understanding of what is going on. And so that consensus has happened in Australia, and I'm not sure from what I was just hearing from Dr. Yulia whether that has actually happened across all communities and the community leaders in Indonesia. We have here huge inequities in Australia, and there is a difference in the education that people have in different communities, and therefore how they fully appreciate some of the discussion that is made by experts. But there is general consensus of what you need to do around this agreement on what the problem is and what we need to do collectively to prevent big problems with with COVID-19, with the disease, and what to protect ourselves and to protect our communities. It extends even to our Aboriginal and Torres Strait Islander people, particularly in the remote and rural and regional remote areas where there's huge anxiety about trying to protect them from the disease and the virus getting there, because they have so much comorbidity and risk factors for getting really severe disease if the virus gets there. And they understand the need to socially isolate and to keep them away from from people who may be people who are at risk of bringing the virus into the communities. So across very different communities, there has been an understanding. And I think here also, all our religious leaders are lined up, whether it's in the mosques, the temples, or the churches, and there has been uniformly a closing of places of worship. This was particularly obvious at Easter, which is obviously a very important Christian celebration, and it will be interesting, and it, I'm sure, will happen around Ramadan and Eid, when these feasts are going to be celebrated, that they will be done at home and with respecting social distancing.
We are, of course, in Ramadan in Indonesia, which is the precious holy month for people of the Muslim faith. And I know my friends there are breaking the fast at home. They're not going out, which is a very different situation for them. Suri, it's good to have you back. Thank you for reconnecting. It brings me to the question I put to you a while ago. You raised concerns that there was some point that if actions weren't taken, you were saying there could be between 11,000 up to 70,000 people infected with the coronavirus in Indonesia by now, roughly. We haven't seen that happen. What's your reading of the current situation, and what do you think has happened since the time that you made that estimate?
Yeah, I think it is clearly shown now that Indonesia at the pace of exponential growth since mid-March, and we are seeing the continuous number of people infected and confirmed through testing. Even though the number, one of our biggest concern is the number of testing in Indonesia, which is still limited compared to other countries, including Indonesia. But exponential growth is obvious, even though there are several good signs in the last few days. Good signs, even though it is not conclusive yet. There are several impacts of large-scale social restrictions start to show some positive consequences. But there are still some work to do, especially in improving law enforcement, provide some incentives and also sanctions for people who deliberately break the government's rule for large social distancing. At the same time, also to work with the provincial governments to anticipate the large scale of people's mobility during this Ramadan, because it is not going to be very easy to change people's behavior in relation to rituals for holy month of Ramadan. But there are several good signs, especially between the provincial governments in Java. They start to see some better coordination to reduce the number and the scale of people's mobility. Another aspect that should be taken into consideration is to reach people, particularly people below poverty line, to enable them to survive in the current economic slowdown. And there are also several warnings from our colleagues particularly from the economists and social scientists, also to advocate the government to pay attention to the people who are not actually poor by the standardized measure of government, but they are considered as lower middle class. With the current shock, economic shock, many of them are vulnerable to poverty and also need to have access to the current government social safety net program.
Mm. And that was definitely a thing that came out strongly in our last webinar, but sort of about making sure that the government measures were targeting those people and including the lower middle class. I'd like to branch that into the level of testing that's available, particularly for those who are unable to access the health services easily. If I could go to you, Dr. Yulia, you have some concerns around the testing regime at the moment. Can you just explain to us what those are?
Yes. Let's see the number. As Pak Sudi already mentioned, we have a very low proportion of tests in Indonesia. It's about 300 tests per million of people in Indonesia. It's very low. It's only half of the Philippines and 1/10 of Malaysia, if I'm not mistaken. It is very low. As I already mentioned before, a lot of suspected patients waiting for the test. So because it is difficult to get the appropriate test, the PCR test, we are now use the less reliable test, the antibody rapid test. We have now, it is quite reliable for those who are ill in the hospital to.
Oh, it definitely has frozen. If I can paraphrase, I know that Dr. Yulia's concern is that there is a quicker test that's not as expensive that's being used to test when it in fact should be used to test people who have already been in hospital rather than giving an answer to whether someone has had the coronavirus or not. Are you back, Ibu Yulia? Can you hear me?
Yes, I'm back.
Please continue.
The internet's very bad. Okay. As I mentioned before, a lot of suspected patients waiting for the test, the PCR test. So then we move to the less reliable test, the antibody test. The test actually needs a lot of study, a further study, to be used as a diagnostic test. It is okay if it is used in the hospital condition, but now the awareness of the people is increasing. They want to know their own condition. So the healthy people try to test themselves with this rapid antibody test. We know that it is not reliable. The false positive and the false negative is very high. So if it is positive, it put a very bad depression for the subject. They waiting for the PCR test, but the psychological condition is dropping. It's bad for them. But if it is negative, we don't know whether it is a really negative or a false negative. But then the negative people quite happy, and then they sure that they don't have the disease. It's very, very dangerous for the containment of the disease. They can neglect the measures to prevent the spreading of the disease. So yeah, I want the test, the rapid test, to be used only in the hospital condition, not to screen the healthy people. That's what happening now in Indonesia.
And that actually ties in nicely with a question that we have from Peter Fanning, who's the treasurer of the Indonesia-Australia Business Council. He was asking about that ability to access widespread antigen testing. Is it just that the system needs more money or more expertise? What do you think would help overcome this problem, Dr. Yulia?
Okay. Yeah. The antigen test, yes, it is expensive, and it takes more time to get the result. What the problem here? First of all, the expertise to get the swab is very limited. That's the first one. The second one, the VTM, the virus transfer media, is also limited. So a lot of people, a lot of patients have to wait for the VTM. And then it should be prepared before it can be run in the PCR. That's also the problem because the facility is also limited. The PCR machine is quite a lot in Indonesia, and we have new machine coming. So the PCR itself is not very difficult. A lot of laboratories can do it, but then to confirm that it is a positive COVID, we should do the sequencing, and that's the culprit. I don't know how many lab in Indonesia not capable. I believe a lot of laboratories capable of doing that, but what do you call it? Yes, eligible to run the sequencing. I don't know how many, but at the beginning, it's only one lab in Litbangkes, and it is very difficult to access. So basically, the problem is the competency of getting the swab, and then the VTM and the processing before the PCR. It is the most difficult to be accessed.
Just briefly going to you, Professor Charles, Canistry, there's a huge need.
Well, first of all, I'll say that there is another issue that does need to be thought about in testing, and that's the protection of those people who are doing the tests. So that personal protection equipment, which in many countries is in real short supply, and you can't really expect people, the health workers who've been trained to do the special swabs and collect them, you can't really expect them to do it on people who are coughing or sneezing and who are unwell, which is why they've come forward for testing. And this is a problem around the world, the lack of masks, gowns, gloves, and visors if you don't have the goggles, and gloves. And it's a big problem. So I think I should just say that I suspect that there is a problem as well as just the testing for the personal protective equipment. I think Australia could be able to help, and we really should help one of our nearest neighbours in terms of assisting improving the laboratory network. There's two aspects of it that, as we have it here in Australia, that's where you collect the samples, and the problems with personal protective equipment, PPE, has been more acute in the clinics in the community, or the GP surgeons, or the primary care facilities, which is one of the major places where people go for their test. Then what happens in the major hospitals, which also run testing services, which tend to be able to get to the hospital pool of that personal protective equipment, and are able much more quickly to get the sample correctly to the laboratory in the right time, so the sample itself doesn't lose any quality. So I think Australia really should be supporting the strengthening of the laboratory network, somehow assisting in the protection of those people, those health workers who are taking the swabs, and improving the number of kits that are available. And this really does mean further assistance to the government of Indonesia and the different provinces to improve the extent of that coverage of a trained laboratory network that can do the tests.
Mm-hmm. And Professor Charles, while I have you with us, we've had a question from the audience from Sarah Fu at the University of Queensland Business School. She is wondering whether the total lockdown, like the one that is being done in India, would be feasible to be implemented in Indonesia, given the current condition. And I'll go to our other guests as well on that.
I lived for 4 years in India before I joined the University of Queensland, and I was working for the UN there, and I was horrified at the suddenness. And I don't want to be too critical of the government of India, but I have to say the brutality in which that lockdown was extremely suddenly implemented, with very poor communication around it, and causing massive population movements that hadn't actually been seen in India since partitioning, when India became an independent nation, when Pakistan and India emerged as countries and separate countries. There were terrible movements of people, and the repeat has been seen. People going back to their village and actually really not able to impose, to practice any forms of social isolation in these mass migrations. I think it went very badly personally. I would hope that any of the lessons that were obvious and apparent from what was done in India would be looked at very carefully by the political authorities and, of course, the health authorities in Indonesia before anything of that scale was contemplated. And that if it was going to happen, and I have to say I'm not convinced it's necessary at the moment in Indonesia, if it was going to be implemented, you really do have to think about the economic consequences of this, because the poor will be the most badly affected, because they will lose immediately their livelihoods. And the poor are often have very limited access to any social networks and any social services and economic protection.
Dr. Suri, I think we have our connection back with you, which is wonderful news. Thank you. I wanted to ask you, and I put this question to you earlier today because I was just going to check that you saw the report from Reuters news organisation, which said that more than 2,200 Indonesians have died with acute symptoms of COVID-19, but were not recorded as victims of the disease. And that's from a review of data from the country's provinces. Now, currently the death toll stands at a bit over 750, I think, but they're saying it's much larger than that. What do you make of those kinds of numbers?
Yeah, I think it is also very obvious from the beginning that we have a problem with underreporting due to what we have previously discussed. the low ratio of testing compared to the total population in Indonesia. And this underreporting phenomenon should be taken into consideration very seriously by the government. So there are several academic associations in the last few days also advocate the government to focus and to document the data for those in the hospital undertaking treatment with important comorbidities. And I think there are two very important comorbidities in relation to death rate for COVID-19, diabetes and also cardiovascular. And these two major comorbidities should be carefully recorded in the hospital, so we can reduce the gap between the actual death and the formal reporting that we have. And it is also not very surprising if we also remember the recent Indonesian Basic Health Survey, the 2018 Indonesian Basic Health Survey, or commonly known in Indonesia as Riskesdas, who indicated very clearly that diabetes mellitus and cardiovascular are two top diseases at the moment. And the comorbidities between these two with COVID-19 is very close, particularly because diabetes can very rapidly deteriorate immunity for people, and also deteriorate the function of vital organ such as heart, lung, kidney, or brain, and blood vessels. So these comorbidities should be taken as a proxy to reduce the gap between the formal recorded death rate and with the actual one that happened on the ground.
Professor Charles Gilks, I'll bring you in here, just looking at that comorbidity issue. Of course, Indonesia also has a high smoking rate. Will that affect the number of deaths from coronavirus?
So if we look at the best available data on that, it's come from China and the early stages in Wuhan and Hubei province, where it was very clear that the people who were getting severe COVID-19 disease and then dying of it, there was a significant preponderance of men in that. And one of the explanations that the Chinese have made of their data is that smoking is one of the major risks for that, or one of the main explanations as to why men were disproportionately getting severe disease and then actually sadly disproportionately dying. China, very few women smoke, it's mainly men. There is also the added problem of industrial pollution in many of the factories and other places of employment, where again men have much more exposure to noxious chemicals in their work environment. The general problem of air pollution, which is common across big cities like Jakarta, Beijing, Sydney during the smoke and the fires that we had, that is experienced by everybody. So that isn't a risk factor. So I think smoking is the number one reason for that difference in morbidity and mortality. And I suspect that when when colleagues in Indonesia start to look at their own data, that they will also see this preponderance of men, and that smoking will be one of the major issues that can explain that difference.
Dr. Yulia, do you have any observations on that, on the comorbidity?
I didn't treat many patients, especially not the COVID one, but yes, that is what we are believe the comorbidity in Indonesia: smoking, diabetes, and hypertension, which leads to cardiovascular diseases, is very high. So yeah, actually we expect more case and more fatal cases, as already mentioned by Pak Sudi earlier.
And a question has been raised in the panel looking at statistical reporting and the need, some of the different practices, I guess, around quick burial, or conducting autopsies and that kind of thing. And also, interestingly, initially there was some stigma associated with having had the coronavirus or a member of your family dying from it, which might have complicated things. Is that still the case, and how much of an issue is that? How much is it an issue that of generating a greater understanding about this disease and not having people shunning others because of it, but finding a way to help? Dr. Yulia, if you would like to go, and then I'll ask Dr. Sudi.
Okay, thank you. Yeah. We are still facing the stigma for those conditions, not only for the disease patient, but also for those who works in the hospital. So the stigma is very wide, and it is because of I go back to the characteristic of Indonesian people who are very ignorant or easily panic. So rumors say that the death body is still a lot of community refuse buried in their neighborhood. Condition goes to the sources in some cities are also banned to go to their home, so they are forced to stay in the hospital. But thankfully, some of the government already prepare the hotels for them to stay during the epidemic, during their time served in the hospital, so they don't have to go to the family, to the their home, but to the hotel that are prepared for the prevention of the spreading of the disease. I believe it is very important for them. Yeah, still we face the stigma, but that's what we can do up to this point.
And so there have been some early murmurings, I guess, that Indonesia feels as though it is winning the battle in some areas on reducing the spread of coronavirus. What are you hearing? And we have a question which is basically, when do you think the restrictions will be lifted and and Indonesia can go back to normal?
Yeah. Before responding to the questions, I would like to follow up the issue of stigma that was discussed by Dr. Julia previously. I think stigma and discrimination was very common, especially in the first few weeks after the announcement of the first case in Indonesia, and mostly due to the ignorance or lack of understanding about the nature of the virus. But this current stigma start to be reduced, particularly when several prominent figures who publicly declared that they were infected and undertook treatment and also experience a good recovery. One of them is actually the former vice chancellor of Hasanuddin University, who was confirmed as a positive case a few weeks ago, but fortunately with very mild clinical symptoms, and he recovered rapidly. And since that, he contributed to communicate to the public that this the stigma should not be attached to the people who were tested, and that we can overcome this, especially if we have a good immunity. And to the second questions, yes, people start to asking very basic questions about how to get to the normal life, and there are several predictions released by the government or released by the community of scientists. The president yesterday or 2 days ago, for example, announced that he hopes that by June we start to see the good signs of significant decrease of the case, and we can start to anticipate a normal life by the second semester of the year. But while this kind of optimistic aspiration is important, I also think that we need to balance it with risk communication to encourage community participations to participate more significantly to preventative measures, such as complying to physical and social distancing, as well as to other preventative measures such as washing hands, and also for the hospital and laboratory setting to improve the ratio of testing that we still have very low at the moment. So I think as mentioned previously,
I was just going to jump in because you mentioned the laboratory testing, which Professor Gilks raised earlier. Do you think it would help if Australia did find a way to assist Indonesia in upgrading the laboratories or helping them to get to the standard they need to carry out more testing, and to also assist the staff working in those laboratories, for instance?
Yes. We start to discuss that actually through several media. For example, through the Indonesian Young Academy of Sciences. It is the equivalent of Australia's Mid-Career Scientist Association in Australia for Professor Charles' concern. We start to see many of the members of the Indonesian Young Academy are Australian alumni. They did their masters or their PhD in an Australian university, and we start to communicate with our colleagues in Australia or also in other countries about the need to enlarge international collaboration to strengthen laboratory and testing infrastructure in middle-income countries such as Indonesia. I believe, as Dr. Julia previously explained, that actually we have some good human capital for that, but we need to strengthen it, and also to consider to distribute these human resources not just to Java, but also to other provinces outside Java, where the facilities and the human resources are less available. So I think scientific collaboration among academia, including between Indonesia's academia and Australian academia, will be very important to prepare us to address the testing and laboratory infrastructure.
And Dr. Yulia, just briefly, I mean, that's a great initiative, those links between Australia and Indonesia. We sometimes forget how strong they are, especially from graduates from universities, and the strong personal links that are still there that we can use to help each other.
could you comment on Professor Charles's idea too of collaboration between the countries on the laboratory testing and helping with staff?
Yes, thank you for the question. Actually, I believe that we need a lot of help. Indonesia is very wide, and the resources are pulled in Java. So with the mudik, we are expecting a lot of cases out of Java, and it needs a lot of resource to combat them. So yeah, of course, support from every angle is should be very welcome. I'm not the one who can give the judgment on that, but I believe yes, we need a lot of help, especially as Pak Sudi already mentioned. We have 4 or 5 major islands in Sumatra, Kalimantan, Sulawesi, and Papua. All of those islands needs a lot of support to face the next wave of the disease of the epidemic due to the mudik, the traditional homecoming. Yes, I agree with that.
Apologies, Ivo. Yes, and given that even though the governments have asked people not to travel for the traditional return to home, it's obviously happening to some extent, and we've got quite a few questions around that. And social distancing. How can we manage this? Perhaps if I could just end briefly with you, Professor Charles, if we're still seeing people moving out to those regional and rural areas at this point, when do you think we might see an increase in cases if they are carrying the virus? What sort of a timeline we're looking at here for that to show up as to whether or not stopping the mudik has been successful or not?
If indeed there's a large movement of people who are infected already with the virus and may not be showing much symptoms, that will have a pretty quick effect in the communities, the villages, or the towns where people are going back to. Whether it will be noticed quickly will very much depend on the alertness of the public health and the clinical teams there and their access to testing. It really just does come down to testing, testing, testing. And one of the problems I think that there is in Indonesia about really why the laboratory services do need strengthening, and that human capital that is really quite strong in places tends to be concentrated in the cities. And people are moving from the cities to areas where there is much more limited ability to where the laboratory services are much weaker, and there are fewer laboratory technicians who are supported to work in the laboratories, to use the skills that they may have acquired through training programs.
We'll have to...
That will be the worry. So
yeah,
it will happen, but it may not be identified. Then you'll have to have indirect measures of disease, which is what... where you're having a different case definition of sort of a COVID-like illness, severe pneumonia-like problems or severe influenza-like illness, which you will have to use as a surrogate for real coronavirus infection and COVID-19 disease, because you haven't got the tests there to confirm it.
So much more that we could discuss. It's raised so many issues, but we do have to leave it there, unfortunately. I'd like to thank the panelists for their time today. It's been much appreciated. I realise how busy you all are. To Dr. Yulia in Surabaya. Have I got that correct? Yes, thank you. I had a Makassar in my head for some reason. But thank you so much. I know how busy you are with your practice. Professor Charles, same, thank you. And Dr. Sudi, So incredibly busy, and thank you for persevering with some difficult internet connections, but there is a sign of the times and we just have to persevere, and we thank everyone who has stayed with us to listen to that discussion. Please rate our webinar. We'd love to hear back from you about how useful it was, about the format, about anything that you'd like to comment on. If you've got some ideas for future webinars, that would be fantastic. I will let you know that we've just confirmed that we are having our next webinar on Wednesday, May the 13th. And one of the guest panelists is Dr. Stephanie Fahey, who is, of course, the CEO of Australia, the Australian government's trade authority. So we're going to be talking again on more economic aspects of coronavirus between Australia and Indonesia. I hope you can join us for that, and thank you for your company for the past hour.